So the question is whether the routine ECG, when the routine ECG is showing a premature ventricular complex, what should we do? So what is a premature ventricular complex? We used to call it as ventricular premature contraction, but now the Heart Rhythm Association worldwide had named it like premature ventricular complex because many times this electrical activity may not produce a effective contraction and a pulse. So it is a spontaneous ventricular electrical activity that occurs before an appropriate sinus impulse is the PVC. What is the prevalence? It is very common in the elderly age group. From the MESA study, it found that at least 2 PVCs are seen per hour in almost majority of the participants. In young age group also, 1 PVC is seen in 24-hour Holter in at least 70% of the persons. And with the advent of these electronic gadgets, absence of PVC is now a very rare phenomenon. How the PVC can manifest? It is majority in persons, it is asymptomatic, and because of the pulse oximeter sometimes may not detect that the pulse, which is a low volume or an ineffective stroke volume, they may present to us with a slow heart rate, but patient will be asymptomatic. Among the symptoms, palpitation is the most common symptom. The post-ectopic beat will have a forceful contraction and patient feel a thud in the chest and in the neck, and they may come to you. If the premature ventricular complex frequency is very more, the effective cardiac output or the forward cardiac output decreases, so they can present it with fatigue or tiredness. The pulmonary venous pressure can rise, so they can present with dyspnea. If the PVCs are very short coupling interval, it can fall on the T wave of the PVC, and that can trigger few polymorphic non-sustained VT and can present as a syncope. However, the repeated studies shows that some patients with frequent PVCs may not be have any symptoms. So there is no linear correlation between PVC burden and the severity of the symptoms. Now, in the history, what should we look for? If there is a previous heart disease and family history of sudden death in a patient presenting with a PVC, that has to be taken seriously. Any medications like beta agonist, tricyclic antidepressants, antiarrhythmics, the medications has to be modified or changed. Now, how to evaluate? The first and the most commonest investigation is a 12-lead ECG. 12-lead ECG, preferably a 12-channel. From this ECG, you can detect the origin, the morphology of the PVC, you can get an idea of frequency, and you can rule out any structural or electrical heart disease from the sinus beats that is present in that ECG. Now, regarding the origin, this is from the Einthoven's triangle and the Wilson central terminal. The Cabrera made this hexaxial reference system, basically the precordial limb leads. It detects the electrical movement in the craniocaudal direction. So a PVC that is originating from the outflow, that means just below the aortic or pulmonary valve, will arise from the lead 1 and the avial region, and it will move towards the body of the or the apex of the either ventricle. So it will be negative in avial and lead 1 and positive in lead 2, lead 3 and AVF. So this is a feature of outflow VPCs. Now if it is arising from the body or at the apex, it will be just the reverse. It will be negative, predominant QRS complex in the will be negative in lead 2, lead 3 AVF, and it will be positive in lead 1 and AVL. Now, to determine from which ventricle it is arising, we have to look for the precordial leads, preferably or especially the V1, because right ventricle is not only right, it is more of anterior than to right side. Left ventricle is more of posterior than to the left. So V1 electrode is positioned in such a way that it can see both right ventricle, interventricular septum, and also the left ventricle. So any VPCs that is originating in the right ventricle will go away from V1, so they will have a preferably, they will produce a negative QRS complex in the V1, while those arise from the left ventricle will produce a predominantly a positive complex in V1. So that's how you can differentiate whether it is arising from LV and RV. So this is an ECG. You can see PVCs and you can see the AVL is negative, so it is arising from the outflow. It is going to the inferior part, that's why 2,3 AVF is positive, and V1 is negative, so it is arising from right ventricular outflow tract. This is another ECG. You can see the predominant complex in 2,3 AVF is predominantly negative, while AVL is positive and V1 is positive, so it is arising from the left ventricular body. So these are how to differentiate the origin of the PVC. Now regarding the morphology, sometimes you can get couplets, a PVC after another PVC. They has to be dealt cautiously. Now in a lead you can get polymorphic different morphology in the same patient, that again suggests a intrinsic structural or electrical heart disease. You have to follow them up. Patients presenting with bigeminy and the QRS is very wide, that is more than 150 milliseconds, again is an indicator of structural heart disease. So these patients has to be followed up further. You can see the first beat in the tracing, the VPC is falling very close to the T wave, and after the third beat that is triggering a polymorphic and non-sustained VT. So a VPCs that is falling very close to the T wave can trigger arrhythmias, though they also has to be tackled cautiously. Now the native ECGs or the native sinus rhythm can give you some clue to the baseline structural or electrical abnormality. This patient with PVC, you can see the QT interval is prolonged. So this is a long QT with PVC which has to be treated. This is a patient who had PVC, but in the resting ECG is showing a complex after the R dash of the RBB, which is suggestive of a epsilon wave and arrhythmic right ventricular dysplasia. This is another ECG and patient showing a Q wave in 2,3 AVF, that is suggestive of a scar in the inferior region. It may be due to MI or it may be due to myocarditis, and PVCs in such patients also has to be further evaluated. So these are the features of high risk PVCs. If there is underlying structural, ischemic or electrical disease, PVC burden more than 2000, complex VPCs, polymorphic VPCs, if the PVCs increases with exercise, and non-outflow tract PVCs, usually the outflow tract PVCs are considered to be relatively benign. Short coupling interval PVCs has to be treated. PVCs with broader QRS complex also suggest structural abnormalities. So the European Heart Rhythm Association give a consensus document on the management of asymptomatic PVCs. If asymptomatic PVCs, the PVC burden is high, just follow them up by an echocardiogram to see whether there is any PVC induced LV dysfunction occurs. There is no treatment, it is advised at that point of time, just for a PVC burden if the patient is asymptomatic. If there is PVC induced cardiomyopathy, and even though if the patient is asymptomatic, you have to treat them. And in those patients with PVCs, you have to closely look for any structural heart disease. If the patient is symptomatic, then you have to treat them. So if the PVC is arising from outflow tract or a fascicle, the class 1 treatment is catheter ablation. Class 2 alternate treatment is beta blocker and calcium channel blocker. If the PVC is arising from non-outflow, they are difficult to ablate, so first option is beta blocker and calcium channel blocker. If the patient has got LV dysfunction and PVC is arising from anywhere from the ventricle, the first option is ablation. If the patient has got LV dysfunction also, you have to ablate them. But treatment for just for a high PVC burden is not indicated. So this is our question. Routine ECG means that probably that patient was asymptomatic, ECG was taken for some other things, so it is a asymptomatic patient. If do an ECG and echo, if both are normal, leave it alone. If it is abnormal, you have to further follow up and treat it. Thank you.